So Dr. Stankiewicz is a assistant professor at Harvard and is the clinical director of the Brigham and Women's MS Partner Center. And he's also teaches me something every time I go to Harvard and hang around at the MS conferences. And he's going to be talking about the older medications and the current pills.
So thank you for bearing with us during this transition, and thank you for having me. I'm really delighted to be here. It's always good to have a chance to share my thoughts with patients about MS, because I like to talk. So, well, so I was asked to talk about the orals versus the injectables. So the first question, we'll just have a show of hands. Who here is on an if you feel comfortable telling us, who here is on an injectable medicine? All right, some hands. Who here is on an oral medicine? Okay, so now what we're going to do over the next half hour, 45 minutes is fight it out. See who is better off on one versus the other. So I think the point that I want to open by making is that I think we obviously think that oftentimes technology is a better thing. So an example of something that would be an update, I would argue, and I have no interest in Apple, in full disclosure. So this is bad. This was not as good as this. I mean, it's these smartphones, you can kind of go anywhere. You can check your email. You can take nice pictures. With this, you could not, right? So certainly technology does allow improvement. However, not everything that is new is better. So that I would make the argument that the original Star Wars was better than some of the updated versions. For example, Jar Jar Binks, not so great. But the question that we're here for is not for me to really take you through what I think is good in terms of development and what is bad, but really, are the pills better, are the injectables better? You know, how do we sort of think about this? And ultimately, I think this boils down to the question of how do you choose a drug? You know, I get asked by these pharmaceutical companies, like, why would you use this drug versus this drug? And it's actually very simple at the end of the day. It's a question of risk versus benefit. So that if you are better off, if there's a huge benefit and there's very little risk, then that's a drug I think you potentially would want to be on, right? But as we know in the MS space, this is more complicated. It's not that straightforward that there's a drug that works perfectly for MS that has no side effects. We're just not there. We keep on trying to get as close to that as possible, but we're not there yet. So ultimately, I think the question of risk versus benefit boils down to what is the efficacy of the drug? You know, how well does it work? How tolerable is it? You know, if a drug is very efficacious and very safe, but nobody can take it because they feel absolutely miserable, then it's not a very good drug, right? And then the last thing is how safe is it? So if you imagine a drug that is perfectly efficacious and you tolerate it perfectly, but if you take it and it kills you, that's not so great either. So it's a balance of these things ultimately. So I just saw a presentation at the Academy meeting that we had, and this person did kind of a word cloud of things that are most in association with what he was talking about, and I thought that was kind of a neat idea. So this is my feeble attempt at a word cloud, and I think the point that I'm trying to make with this slide is that my perspective is that the ultimate decision around an oral versus an injectable is what you value most. So you can see here for the injections, you see efficacy, tolerability, and safety, and you can see that the safety looks bigger. Because I think the bottom line, you know, and I think people appreciate this, but the bottom line with the injectable medicines is they've been around for a long time. And so you really know what you're getting. And in general, I think that we think the safety profile of the injectable medicines is good. We don't see oftentimes a lot of trouble. So then we have the orals, and so then the question is, what is the advantage of the oral? So one advantage is that it's not an injectable, right? I mean, that's a pretty obvious statement, right? So that's more palatable, I think, for most people. The other thing is, I think if you look at my bad attempt here at a word cloud, efficacy and tolerability I think tolerability is probably generally a little bit better because it's an oral. And efficacy, actually, I would make the argument, and I think many would agree with me, I think the efficacy of the orals is probably better than the injectables, generally. We'll kind of get into specifics a little bit. But safety is not as well defined because these drugs have not been out as long and exposed as broadly as the injectable medicines. So that's so really, I think the decision around an injectable versus an oral really is summarized in this slide. It's really kind of what do you really want from your medicine. So people, statisticians will always say, when you compare these drugs, you can't really compare them very well. You shouldn't compare across trials because there are different variables. You know, what are the patients like that are enrolled in the population? How do you collect the data? How many patients drop out, and you know, this sort of thing. Having said that, we're kind of stuck because we can't, if we don't have a comparison, we have to take our best guess. So I'll show you, we do have two studies, one that is kind of a more rigorous look and the other that's not quite as rigorous a look at sort of direct head-to-head comparisons. So I'll show you that because that gives a little bit of a flavor. But absent that, we have to just kind of take our best guess at efficacy around this. So we're talking about, so for, you know, I just to give you a little bit of the organization of what I'm talking about now. So I told you that there's sort of, you're judging risk versus benefit around efficacy, tolerability, and safety. So for the injectables, I'll talk about efficacy, then I'm going to talk about tolerability, and then I'll talk about safety, and then I'll do the same for the oral. So it's a very organized way that we're doing this. Okay, so injectable efficacy, you can see that Copaxone reduced relapse rate about 29% in placebo-controlled trial. Rebif and beta-serone, 33%. Avonex, depending on, there's argument about this, but if you use an intention to treat analysis, it reduced relapse rate about 18%. MRI, so again, you have to try and compare apples to apples. So one of the ways that we look at this is to compare gadolinium enhancement, which is the breakdown of the blood-brain barrier that Dr. Weiner was talking about, which is kind of new inflammation. So this is one way to look at how active the disease is on these metrics. So gadolinium enhancement was reduced 35% on Copaxone, 33% with Avonex, and actually the higher dose interferons had a stronger result. This is actually a different metric, but this has been, gadolinium enhancement has been looked at in this situation too, and was on the order of about 85%, I recall. So disability, Copaxone reduced disability 12%, and actually it was a non-significant result in the original trial. Rebif and beta-serone 30% and Avonex 37%. So these numbers, you can see that they're mixed. Now I'll just make one comment about this, which I think is worth making. So I told you the statisticians, when I put a slide up like this, they go wild. Is there anybody that's a statistician in the room? Okay, good, so I'm safe. So, this is kind of the placebo-controlled trial. One thing that's sort of interesting is that two of these companies, EMD Serono and Biogen, oh no, I'm sorry, pardon me, EMD Serono and Bayer sponsored studies where they did kind of head-to-head comparisons between interferon and Copaxone. And the idea was they thought, well, our drug is going to do better because the onset of the drug is going to be faster, and so we'll show a better effect sooner. And so they designed the trials in this way, and they spent a lot of money to do these trials. So there were 3 trials, actually, Beyond, Become, and Regard studies. And at the end of the day, what happened was that Teva was the one that made out like a bandit because they spent not a dime of their money, and sort of these drugs were shown to be basically the same in terms of efficacy. So I think that that's just worth mentioning. So in terms of choosing between those, I would say in general it's a wash. I think there's a question in my mind whether or not higher dose interferon may work better than lower dose interferon, and there are actually 2 studies to support that as well. So beta-seron and Rebif may work a little bit better than Avonex. And then the last thing to say about this, and then we'll move on, is that there's a pegylated interferon coming out. So it's basically Avonex, but it's kind of, they're attaching a sort of another molecule to it to make it so it's injected every 2 weeks and probably to work as well as the high dose interferon. Okay, so then we're talking about tolerability. So outside of the injections, I would make the argument, I think in the long run, the injectable medicines are pretty well tolerated. I imagine that some of you that are on the drugs have been injecting for a long time, and really you have the injection and you're kind of used to that and not really a lot of side effects around it. Copaxone, I would say, is a pretty clean drug. I mean, the main thing is where you actually inject. There's a variety of the kind of localized injection site reactions that people get. Some will get very mild reactions. Some will get these big welts. In general, it's well tolerated. The other thing that happens, in the 2-year trial when they did it, about 12% of people had this reaction where they felt like they couldn't breathe, flushing, their heart racing. We think that what happened to those people is that they accidentally injected into the vein, and it was absorbed more quickly. And it's something that's self-limited. It goes away, and it's not anything to really to worry about. So that's sort of in a nutshell in terms of tolerability, Copaxone's issues. The other thing to say, which I think you probably know, is now there's a 3 times a week Copaxone available. And so that's nice in the sense that it can cut down on injection reactions. That's a much more complicated story, which we could talk about at a certain point. But anyway, it's interesting and maybe something potentially good. In terms of tolerability for interferons, the main thing that you see is flu-like side effects. So feeling achy, kind of fatigued, almost like you feel, as I hear described by people, hungover. That's something that at first is more noticeable. And for some people it's persistent, but in general I would say after the first 6 months or so it tends to improve. And in fact, what we do with the injectables is we start kind of at a lower, not the injectables, but with the interferons, we start at a lower dose and then kind of gradually work our way up to help people adjust in. And I'll just put out one tidbit also that I find that the 2 things that really help with the flu-like symptoms are really keeping hydrated. And the other thing is naproxen, for whatever reason, seems to work particularly well for that. Okay, so then we're on to safety of injectables. So I think the highlight, and I sort of mentioned this, but it's good to make it maybe explicit, is the amount, like the number of years that these drugs have been out. So the Copaxone has been out 18 years. Rebif has been out beta-seron has been out 20 years. Rebif has been out 12, so it's the reverse of that. And Avonex has been out 18 years. So really, you know what you're getting. It's really hard for me to imagine that all of a sudden we're going to start seeing something crazy on one of these drugs. It's hard to pull out things that are really threatening on these drugs, but in the original sort of Rebif group, there were some patients that wound up developing liver failure. But they, when we check, I think if you're on interferon, you know that your physician will check your liver periodically. And that's, in that group, actually, these patients were also on other drugs that were actually more toxic to the liver. But because sort of out of an abundance of caution, we do watch this. The other thing that I've seen on, you kind of are a product of what you've experienced and remember. I've had a patient that was on an interferon that committed suicide. Depression, sometimes people say, can be associated with interferon. And he was definitely on the interferon. Whether or not it was related to the interferon or not, I don't know, who knows. But you remember that because that's, obviously not a great thing to have happen. Copaxone, really, it's been pretty clean. You hear that things come up, but when you have a drug that's out so much, there's nothing that's really been obviously associated from a safety perspective. Okay, so we talked about the efficacy of the injectables. So kind of in general, like a reduction of relapse rate about 30% broadly for the drugs. We talked about tolerability. So mainly the injection site reactions to interferons, flu-like symptoms. With Copaxone, really just the injections themselves. And we talked about safety. So safety really broadly looks good, and the drugs have been out for a long time, so you know what you're getting. So the orals. If you look at efficacy, you can see, I think, that these numbers are better. So the relapse rate reduction of 54% with Gilenya, Tecfidera a 53% reduction, and Aubagio 31% reduction. In general, when we think about these drugs, and I think broadly if you were to ask MS experts, we tend to think that there's sort of the first tier of drugs in terms of efficacy, which are the injectables and Aubagio. And then there's a second tier, which is Gilenya and Tecfidera. Okay, so I think that's the broad perspective. But if you look at the MRI results, I don't know if you can see it, but Gilenya reduces gadolinium enhancement 82%, Aubagio 80%, and Tecfidera 90%. So you can see how those numbers, again, look better than what we saw with the injectables. And disability, around 30% for all of them, with Tecfidera approaching 40%. Again, you have to be a little careful about comparing across trials, but we have, in general, when you look at those numbers, they look, for at least Tecfidera and Gilenya, better than what you see with the orals. Now, one thing that I think is a larger question, which I'll just toss out there, I get excited by these 50% reductions. I think, well, that's great, and in general, I think I prefer the idea of having someone have like less relapses, less MRI activity, et cetera. I mean, that's an obvious sort of statement. I think one thing that is a dicier business, which I think is worth keeping in mind for this discussion, is some patients really need that additional sort of efficacy, and then others, I think, don't really. I mean, you know, and the reality is if you were, and I haven't, you know, I've seen some of these analyses. I haven't really thought about this recently, but if you take someone and follow them over 2 years, you would have to enroll like 15 patients to see a difference between these two drugs or something like that. So the question is how, in practice, how meaningful is that difference, which so I get excited by the numbers, but I wonder practically how different things are in that way. So now we're talking about tolerability. So I think Gilenya is a pretty well-tolerated drug. There's not really much that comes up in truth. Really, occasionally I'll hear patients complain of some fatigue, but that's not a persistent complaint. And I don't know that I especially associated that with the drug. It's so common in MS in general. Aubagio, the two things that we can see, there can be some stomach upset. Again, that's pretty mild. That hasn't been a deal breaker or a problem for anyone, especially. Hair loss is something that can be bothersome to some people. So people can get like a hair thinning when they first take the drug. And then as time goes on, that tends to sort of improve. But that can be bothersome to some patients. I'd say it's 15 to 20% of patients where that can occur. So Tecfidera, I think if Tecfidera has, I would argue if Tecfidera has a fault, the main thing is tolerability. So at the beginning, it can be bothersome to people. Most people, I would say, get flushing. I see some people nodding their heads here. And stomach upset. So, and stomach upset can sort of range anywhere from nausea, vomiting, diarrhea, abdominal pain, cramping, and this sort of thing. So I would say because of the tolerability issues, 15 to 20% of people just really can't tolerate the drug. I'll give you, if you're one of these folks or you know of someone, I'll give you a little tip, which I think works beautifully, actually, and is, I feel a little bit like in The Graduate when he says plastics when I tell people this, but peanut butter. Peanut butter works very nicely to help with these symptoms. So taking like a scoop or two of peanut butter, the healthy kind. I don't endorse any particular one, Jiffy versus Skippy, et cetera, but a spoonful of peanut butter before taking the drug, at least in the first couple weeks, really seems to help with this. Something about the fat. Anyway, I could go on with stories about that. But so tolerability of Tecfidera, at least in the short term, is imperfect for a lot of patients. So then we really sort of cluster around this question. I guess in some ways this is kind of the most important part of the talk. The question is, well, what is the safety of these oral drugs? So great, they work better in general. Great, they're more, I don't have to take an injection. But what am I sacrificing in terms of safety? So the first thing to say is you're sacrificing the amount of time that we have sort of observing people on this drug. So that Gilenya has been on the market for 3.5 years. That was the first oral released. Aubagio for 1.5 years, and Tecfidera recently had its 1-year anniversary. The other thing to say about this is how long they've been in general circulation. Gilenya has about 100,000 patients that have at least gotten 1 dose of the drug. So it gives you a sense of how broadly. The uptake of Tecfidera has been pretty broad, so this exposure has been, even though it's been only 1 year, it's been a pretty broad exposure. And then the other thing you have to keep in mind is that these medicines sometimes can have previous histories too. So Gilenya was, they did a phase 2 trial and patients were carried through the phase 2 trial. So there are some patients out there that have been on this drug 5, 6, 7 years. Okay, so we haven't seen those patients, we don't see them dropping dead or anything, and so this is good. Aubagio doesn't have as much long-term exposure, through some patients in phase 2 trials, but it also has a precursor compound which is very similar. The active arm is really essentially the same, called leflunomide, which is a medicine that's used to treat rheumatoid arthritis. And so we have a very large exposure of patients to that drug. Aubagio is actually sort of used, they used rational drug design to make it a better sort of molecule. And leflunomide in general, safety issues haven't really been too huge. The one thing that has come up with leflunomide, and there's argument around this with Aubagio, but certainly there's labeling around this, that women sort of in childbearing age have to be very careful with this drug because it can cause potentially damage to the fetus. So it's labeled pregnancy category X. So when they do these studies to look at patients that have been on Aubagio to see whether or not there's been damage to the fetuses, in general they find that the experience is in line with what we see with interferons and other drugs. So it doesn't, at least the patients that have been on the drug that have been seen, it doesn't seem to be that different. But there is a concern because in animal models, there can be defects in the mouse and this sort of thing. And so I think it's worth just pointing that out. To talk a little bit more about so one other thing I want to mention, then I'll drill down a little bit more into specifics around safety. So I told you that Tecfidera has been out for about 1 year. There is a precursor compound also, Fumiderm, and that's kind of a neat story. So like Dr. Weiner was saying when he said that the interferons were originally developed because they thought that MS was a virus. So this is kind of a neat story. So the Tecfidera came into being because some patients, so this was a drug that was used to treat psoriasis in Germany. And so some patients that also had MS, that had psoriasis, were treated with this drug and they seemed to do better. And so this is kind of just a serendipitous discovery. And many years later and millions of dollars, we have this drug now for patients. But because this drug is used to treat psoriasis in Germany, there's a pretty extensive experience with this, with the precursor drug at least. The drug is, Fumiderm is used at a little bit higher, it's sort of it's scaled up, but it's used at a little higher dose, and it's a little bit dirtier a drug. But in general, we have this background of use in Europe, which I would say, broadly speaking, looks pretty safe. I'll drill down into specifics about that in a minute. So let's go back to Gilenya. So I told you already that Gilenya, the efficacy is good. I mean, it reduces relapse rates about 50%. I told you that the tolerability of the drug is good. It's a once-a-day oral, so that's appealing. So then what are the issues around safety? So the two things that, or there are really 3 things that we have to look out for on Gilenya. The first is when you take the first dose, most people's heart rates drop 10 to 15 beats. Which for most people isn't a big deal. We bring them in, we observe them for 6 hours, but there's a certain small population of people, and this number is kind of being defined better, but I would say it's maybe 0.5% or potentially even lower of patients that take this drug and their heart slows enough and the rhythm changes or something like that that we get nervous and we ship them over to the hospital. And we watch this very closely because when the drug was within the first year of release, there was one patient that was on 2 other drugs that slowed the heart, got Gilenya and never woke up. So that really created a big stir, a lot of concern. A lot of people were very nervous about it. But since then, this has not been a recurring theme, just to say. And I mean, I don't know that it's really especially productive to go into this in detail, but there are reasons to think that at the end of the day, this really shouldn't be that huge an effect or problem. But anyway, this is one thing that we think about with this drug. Infection. So we know that patients are slightly more predisposed to develop lower respiratory tract infections like pneumonias. It's a small increase. It's nothing too impressive. We do think that there may be a little bit of a bias to develop problems from herpes virus and the shingles virus. And so we like to screen to make sure that people have been vaccinated beforehand. And then the other thing that's come up is this PML. So PML you may have heard of in the context of Tysabri. It's this infection of the brain that was originally seen in HIV, AIDS. And in the HIV population, if you got it, you wound up dying. In this day and age, if you get it on Tysabri, it's about a 30% chance that you'll wind up dying. There have been reports of PML with Gilenya, but when you look at those reports, it seems like oftentimes it's patients that have been on Tysabri that then transitioned to Gilenya, and probably it was just like the Tysabri that caused it. There was one other case that was just a weird case, which may have been the Gilenya that did it, but the whole thing is just a little strange, so I don't really know. I don't know, let's put it this way, if there's an association, it's a weak association, it's not a strong association like what we see with Tysabri. Aubagio, I mentioned how there are these problems with fetal development potentially. There's argument around that, but potentially it's something to think about. And then, rarely there can be problems with the liver, and so we monitor the liver. Nothing too awful has been reported, but just to mention that. And it may, in theory, predispose you to infection a little. Again, not a huge thing. Tecfidera. In general, I think one of the reasons that this has been an appealing medicine to a lot of people is the safety profile actually looks pretty clean. And there is this background history of use of Fumiderm. There have been two. There was a person that wound up dying that we heard about who had chronic lung problems and wound up developing a pneumonia, was on Tecfidera, stopped the Tecfidera a week or two before, maybe a week before being on it, and wound up succumbing to the pneumonia. So just to put that out there. There has been a case recently that we just heard about of a patient that was on Tysabri, stopped the Tysabri, started the Tecfidera. Within a couple months, the PML was identified. Again, we think that that's probably a case of PML on Tysabri, but the drug gets tagged just like Gilenya gets tagged because they were on that drug, at least when it was discovered. And then the last thing to say to fill out the safety profile is this experience in Germany. I told you that it's not a perfect comparison because this Fumiderm is a drug that is a little dirtier and used at a little higher dose at its peak, I guess. But there were 4 cases of PML reported in the Fumiderm population. That's with over 180,000 patient years of experience. So this is a drug that's used very broadly, been used very broadly. And those actually, when you drill down and look at those cases, 3 of the 4 cases I think could really very easily be explained by other things. So there was a patient that was on Raptiva, which is a drug that's known to cause PML. There was a patient or 2 other patients that were on other immunosuppressive drugs in conjunction with Tecfidera, so it could have been related to those other drugs. There was one case which I think may have fit a little bit better for maybe being related to the Fumiderm. It was an older gentleman who had chronically low white blood cell counts as a result of being on the Tecfidera, and it was never sort of adjusted, and that may have been related. Hard to know for sure. But anyway, there hasn't been anything reported in the year that the drug has been out that's been clearly a case of PML on Tecfidera, absent this case with the Tysabri. So that's really kind of what we know about the safety of these drugs. I just want to mention a couple other things, and then I'll stop. I should probably track time a little bit better than I am. Let's just see where I am. Yeah, I'm doing right about on time here. That's good. So we do have two head-to-head comparisons. So this is actually a pretty well-designed study, and we get a pretty good sense of where at least Avonex and Gilenya stand. So Gilenya, compared to Avonex in a one-year trial, pardon me, the patients that were on Gilenya, there was a 52% reduction in relapse rate relative to Avonex, so actually a pretty impressive result, I would say. 55% reduction in gadolinium enhancement relative to Gilenya, and a 31% decrease in brain shrinkage relative to Avonex, I should say. So very clearly the fingolimod did better than Avonex. It's worth mentioning that there was a trend in this trial towards a change in disability at 1 year. They weren't really, when they designed the trial, going to look at that in particular, but not significant, but a trend. So, and then there's another trial looking at Copaxone versus Tecfidera. This trial is not as well designed because it wasn't blinded, so the patients knew what the drug was on. And so this potentially could influence a number of factors, and so that makes it a dirtier design. One thing that probably is good information from this trial, though, is the MRI effect, because what happens is, they do MRIs in these patients, and then they send it by, computer to somebody who doesn't know a lick about the patient, doesn't have any idea whether or not they're on Gilenya or Copaxone, doesn't probably even know the patient's name or where they live, et cetera. So that's very easy to blind. And there was a reduction in neuroenlarging T2 lesions, so 71% reduction versus 54% for the patients on Copaxone. So that was a significant result. Gadolinium enhancement, there was a reduction of 74% versus 61%. Now, one thing, I told you this already. If you remember what I told you about how Copaxone did with gadolinium enhancement in their original trial, it reduced gadolinium enhancement about 30%. So you can see that this number is stronger. So it really does make a little bit of a difference what patient population you're using. So this is actually better information than sort of the other things, just putting these medicines up side by side. So I think that's worth mentioning. There was also a significant result in relapse rate reduction, 44% versus 29%. Disability progression, there was kind of a split, but there weren't enough patients enrolled to make it significant. And in fact, in this trial, for whatever reason, and this happens occasionally, neither of the drugs differed from placebo in how they did disability-wise. So this is just kind of an overall kind of visual of what I just told you. You can see at the very top of this blue bar, in terms of reduction of relapse rate, is Campath, then Tysabri, and kind of goes down from there. But just to point out that, so Gilenya is here, Tecfidera is here, and then the interferons and Copaxone are kind of in here, so it gives you a sense. Okay, so then, I guess in closing, yeah. Okay. Now again, statisticians would not like me doing this, and there is probably, part of the reason I talk about this, you could say, well, this is not very rigorous to do, but the reality is oftentimes we see that oftentimes these results are duplicated in other trials. So I think it's actually, everybody talks about how you shouldn't do this, but I think it's actually better than people give it credit for in terms of pegging how well these drugs work. So let me just see one other thing. Okay, so are we ready? Can I move on or not yet? Okay, people have absorbed it. So we come back to the original question, which is, are the injections or the orals good or bad? And I think really it's, as I said, it depends on what your perspective is in terms of safety versus efficacy, tolerability, and safety. So I think you have maybe after I've talked about this a little bit, a nuanced view that these oral drugs I don't think are unsafe, but we don't have as much exposure. And there are things that have come up that you sort of wonder a little bit about. sometimes. We don't wonder as much with the injectables, but you do potentially sacrifice some efficacy. What does that mean? I don't know. And the other thing that you would sacrifice is having to actually do the injections. So I think that's kind of the bottom line. Now, the other thing I was asked to talk about is what does the future look like? So I think this is what the future looks like a little bit. You can see that there are flying cars, right? And you can see that these buildings look very sleek, and this looks like a very pleasant place. You can see it's sunny outside, so we haven't totally killed the environment with our sort of pollution, et cetera. But just to say, where are things headed with this oral versus IV, oral versus injectable? So companies continue to work on making the injectables more and more palatable, like better injectors and this kind of thing. I think there's study around how to make, not that I think Tecfidera in general is intolerable, but there's study around are there ways to make it more tolerable, so people are working on that. There's another drug called laquinimod, which is in the pipeline, which they're working on a higher dose than the original dose that was trialed. It looks like a pretty tolerable and safe drug, at least what we've seen so far, so that's interesting. Let's see. There's a drug called diclizumab, which is an injection. It's an every 2-week injection, which we probably will, the phase 3 trial will be, we'll get the results towards the end of this year. The preliminary, the phase 2 trial, which is sort of the earlier look at this, showed pretty good results, so that may be another medicine that we'll have for the future. Let's see, is there anything else? And then I mentioned the pegylated interferon, so that's something that is going to be like an Avonex, but basically it's going to be every 2 weeks and probably will work a little bit better than Avonex. People are always working on other things. You know, we talked a little bit about vitamin D already. We're wondering about probiotics, which we mentioned. So I think the other question is whether or not you can add on other orals that are cheap. You know, ideally, you could imagine combining some of these things, but these drugs are, as I think you know, very expensive. And so how much room we'll have to add sort of, let's say, Tecfidera or Gilenya to Avonex to really get a better efficacy, who knows. But we're working on combining with other things. You know, how much do we benefit people if we put people on vitamin D, or how could we benefit people if we put them on a probiotic? Another thing that just came out at the Academy meeting, which is sort of interesting, is a group that added estrogen, sort of a form of estrogen, onto patients and found an additional reduction. I think they were added to, estrogen was added to Copaxone, is my recollection. So I think we're always trying to optimize treatment and add to try and sort of make these drugs work or make things work as well as possible for people. So that's, and then the last thing I would just make as a comment is what I've talked about really is in a relapsing population. So the other thing that we need to do is find in progressive disease drugs that really work. And there are trials with some of these drugs in progressive disease that, so we'll see whether or not they could potentially work in progressive disease. Based on mechanism, we think that there could be a role for Gilenya, for example, or there could be a role for Tecfidera. There's a trial that's going on right now with Tysabri, which you know, I didn't really talk about because I'm talking about orals versus injectables. I guess an IV is an injectable, but I took it very rigidly here. So there's a trial in progressive disease going on with Tysabri, which we'll get a readout on. So it'll be interesting to see over the next, I think both the Tysabri and the Gilenya trial, Gilenya I know is going to read out sort of in the spring of next year. Tysabri I'm not exactly sure offhand when, but I think within the next year to year and a half. Okay, so I guess that's my summary.